Bismillah Rahman Rahim. Today's lecture is about tuberculosis. So, first of all, we should know about what is tuberculosis. Tuberculosis means is caused by infection with Mycobacterium tuberculosis, which is a part of a complex of organisms. Most common of them are Mycobacterium tuberculosis, Mycobacterium bovis, which has cattle source, and Mycobacterium africanum, whose reservoir is in the humans. As an estimated 9.56 million new cases were recorded in 2014, with the majority presenting in the world's poorest nations, which struggle to cover the cost associated with management and control programs. Regarding pathology and pathogenesis, Mycobacterium tuberculosis is spread by inhalation of aerosolized droplet nuclei from other infected patients. One inhaled, the organism lodge in the alveoli and initiate the recruitment of macrophage and lymphocytes. Macrophages undergo transformation into epithelioid and Langerhans cells, which aggregate with the lymphocyte to form the classical tuberculous granuloma. Numerous granuloma aggregate to form a primary lesion called Ghon's focus. A pale yellow caseous nodule, usually a few millimeter to 1 to 2 centimeter in diameter, which is characteristically situated in the periphery of the lungs. Spread of organism to the hilar lymph node is followed by a similar pathological reaction, and the combination of the primary lesion and the renal lymph node is referred to as primary complex of Ranke. Reparative processes encase the primary complex in a fibrous capsule, limiting the spread of bacillus. If no further complications ensue, this lesion eventually calcifies and is clearly seen on a chest X-ray. Lymphatic or hematogenous spread may occur before immunity is established. However, seeding secondary foci in other organs, including lymph nodes, serous membranes, meninges, bones, liver, kidneys, and lung, which may lie dormant for years. The only clue that infection has occurred may be the appearance of a cell-mediated delayed type hypersensitivity reaction to tuberculin, demonstrated by tuberculin skin test or interferon gamma release assays. These most are used to diagnose the latent tuberculosis. If these reparative processes fail, primary progressive disease ensures. The estimated lifetime risk of developing disease after primary infection is 10%, with roughly half of this risk occurring in the first 2 years after infection. So, what are the clinical features? For primary pulmonary tuberculosis refers to the infection of a previously uninfected individual. A few patients develop a self-limiting febrile illness, but clinical disease occur only if there is a hypersensitivity reaction or progressive infections. Progressive primary disease may appear during the course of initial illness or after a latent period of weeks or months. And miliary TB. Blood-borne dissemination of infection give rise to miliary tuberculosis, which may present acutely but more often is characterized by 2 to 3 weeks of fever, night sweats, anorexia, weight loss, and dry cough. In miliary tuberculosis, hepatosplenomegaly may develop, and presence of a headache may indicate coexistent tuberculous meningitis. Auscultation of the chest is frequently normal in miliary tuberculosis, but in more advanced disease, widespread crackles are evident. Fundoscopy may show choroidal tubercles. The classical appearance of chest X-ray are of fine 1 to 2 millimeter lesions distributed throughout the lung fields, although occasionally the appearances are coarser. These are called millet seeds. Anemia and leukopenia reflect bone marrow involvement. Cryptic miliary TB is an unusual presentation, sometimes seen in old age. And regarding post-primary tuberculosis, refers to the exogenous or endogenous infection in a person who has been synthesized by early exposure. It is most frequently pulmonary and characteristically occur in apex of an upper lobe where the oxygen tension favors survival of a strictly aerobic organism. The onset is usually insidious, developing before over several weeks. And systemic symptoms of TB include fever, night sweats, malaise, loss of appetite, and are accompanied by progressive pulmonary symptoms. Radiological changes include ill-defined opacities in one or both of the upper lobes, and as progression occurs, consolidation, collapse, cavitation develop to varying degrees. It is often difficult to distinguish active from quiescent disease on radiological criteria alone, but the presence of miliary pattern or cavitation favors active disease. In extensive disease, collapse may be marked and result in significant displacement of the trachea and mediastinum. Occasionally, a caseous lymph node may drain into an adjoining bronchus leading to tuberculous pneumonia. So, here are the common clinical presentation of pulmonary tuberculosis. Most often, patient present with cough, hemoptysis can occur, fever, unresolved pneumonia, and if there is pleural effusion, it's of exudative and lymphocytic. Sometimes patients are asymptomatic and we only get findings on the x-ray or in the sputum. Weight loss, general debility, spontaneous pneumothorax is sometimes associated with pulmonary tuberculosis. And what are the complications of chronic pulmonary tuberculosis? These include massive hemoptysis or pulmonale due to the lung fibrosis, emphysema, atypical mycobacterial infection can be there once the TB is after the treatment of TB. Lung and pleural calcification, aspergilloma. Obstructive airway disease can result during TB or after, even after when the treatment is given to the patient. Bronchiectasis can be there, and bronchopleural fistula, if there is a fusion, it can develop. And empyema necessitans, laryngitis, enteritis, anorectal disease, amyloidosis, Ponsted polyarthritis are the non-pulmonary manifestation of the tuberculosis. Systemic presentation of extrapulmonary tuberculosis: headache, vomiting, seizures, delirium, lymphocytic meningitis, space occupying lesions, tuberculoma, kyphosis, card compression, abdominal mass, source abscess, chronic backache can be there. If the patient develops ascites, it's same like of the pleural fluid. It's exudative lymphocytic, mesenteric adenitis, intestinal obstruction, cranial opacities, lymph node enlargement, pericardial effusion, constrictive pericarditis, monoarthritis, hematuria, dysuria, infertility in women, epididymitis, and anorectal ulcerations can be there. So, how to make the diagnosis of tuberculosis? First of all, specimen required. For the pulmonary tuberculosis, sputum is best, and it can be spontaneous or it can be induced by hypertonic saline. And if the patient does not produce sputum even on inducing it, we can go for bronchoscopy with lavage and washings of the affected part of the lung. And in children, mostly gastric washings are done because they usually do not produce the sputum. And for the extrapulmonary tuberculosis, we can get fluid like CSF, ascitic fluid, pericardial, pleural, joint fluid. Although the yield is not that much good in these fluids. Tissue biopsy can be done, like bone marrow and liver biopsy may be done in case of disseminated disease or like in cryptic or miliary tuberculosis. So, what tests can be done on these specimens? In case of tuberculin skin test is usually done nowadays for latent tuberculosis, and second one is the IGRA. One mostly available in Pakistan is T-spot TB, and if the sputum is there, we can go for Zn strain or Oramine Rhodamine strain. And nucleic acid amplification tests are more sensitive than these conventional strains, and one example is the expert MTB Rif which is available in Pakistan. So culture can be done solid media. The bug grows slowly on these medias are the LJ medium and Middlebrook, and then liquid media the growth is quite rapid, and MG80 is one of the example of it. And in pleural fluid adenosine deaminase level can be done, which help to support the diagnosis of tuberculosis, and in pleural to be as well pleural biopsy can be done. So what's the management of pulmonary tuberculosis? The standard regime consists of an intensive phase of 2 months of isoniazid, rifampicin, Pizarday, and ethambutol, and then the continuation phase consists of two drugs of INH and rifampicin. Next, 2 months, another regime consists of 2 months of isoniazid, rifampicin, Pizarday, pyrazinamide, and ethambutol, and 4 months of continuation phase of INH, rifampicin, ethambutol, and it applies only in the countries where high level of INH resistance in TB patients is there, and where INH susceptibility testing is not done before the continuation phase begins. And during the treatment, the patient is monitored by for his clinical improvement, as well as if the patient is producing sputum is analyzed at the end of 2 months, and at the end of 4 months, at the end of, sorry, 5 months, and at the end of the treatment. And X-ray can be used to check clinical improvement. So what are the main adverse reaction of the first line anti-tuberculosis drugs? Like INH, it's cell wall, it inhibits the cell wall synthesis. Its major side effects include reaction, peripheral neuropathy, hepatitis, and rash. Regarding rifampicin, major side effects include it can be anaphylaxis reaction, GIT disturbance, rash, hepatitis, and thrombocytopenia can be there. Regarding pyrazinamide, hepatitis, GI disturbance, and hyperuricemia can be there. Ethambutol major side effects include retrobulbar neuritis, arthralgia. Thank you so much.